Good morning to all distinguished guests, respected faculty members, colleagues, and participants. On behalf of the Cardiological Society of India, I warmly welcome you all to today's observance of the World Hypertension Day 2026, which is themed as Controlling Hypertension Together. Hypertension was, is, and remains the leading risk factor for heart diseases, stroke, kidney disease, and premature mortality worldwide. Despite all advances in diagnosis and treatment, awareness, regular monitoring, and long-term treatment adherence remains major challenges. In fact, in India, 50% of the hypertensives are not diagnosed. Those who are diagnosed, only 25% take medicine regularly, and proper control can be achieved only in around 10 to 15% of the patients. This is an abysmally low number of subjects. In this context, participation of all the stakeholders, patients, providers, doctors, community workers, the government, everyone is very important in controlling hypertension together. Today's program brings together eminent experts and leaders in cardiology to discuss practical strategies for implementing blood pressure control, encourage home monitoring, and ensuring better patient compliance with therapy. I am confident that the deliberations and the panel discussion will provide valuable insights and strengthen our collaborative commitment towards better cardiovascular healthcare for our communities. Thank you. May I now request Dr. S.S. Mishra, convener, CSI Hypertension Council, to start the deliberations. Dr. Mishra, please.
Yes, sir. Can I share it? My slides?
Yes.
Is it visible, sir? Hello?
No, yes, go to share.
Should I go ahead?
Yes, your slides are not visible.
Sir?
Not visible. Your slides are not visible.
Sir, I have attached it.
Kishorji, are you there?
Yes.
Can you please guide Dr. Mishra, sir?
Yes, I am there. I am just...
Dr. Mishra, follow the instruction of our technical team. Please follow. Kishorji, please guide him.
Share the slides first. Go right, there is a share button.
Can someone help me in the technically about this? I am sharing this. It is looking here. Hello?
We go to the go to the share button.
I am resharing it again.
Go to share button, please. On the bottom right. Second row, there is a share button. Share button. Please click on that.
Yes, sir. Share button I am shared.
Sir, once you click share screen, you will get all the options like desktop, screen.
No, I am just putting it to the share.
No. Once you click on share screen, share button, right? Share.
Yes.
The another window will open with icons, correct?
M is the opening after putting here.
No. You are in a Zoom, sir. What you can see in Zoom now?
I see everybody.
Okay, now you have to click share option, which is
Yes.
available bottom center. Correct?
Yes.
Just
Clicked.
click that. It will open another window. Correct?
Yes.
In that select a screen. Select a screen. Just share again. Click share again.
Oh, it is not visible. Also, system audio is there. Entire screen window.
Enter screen. Enter screen. Enter screen. Enter screen.
Okay.
Share. Then again there is a share option. Just click that.
It's not opening. Entire screen not opening.
No. Entire screen. Just click entire screen, sir.
Yes,
Select
I
that.
clicked.
Select. Select.
Yes.
Then there is a bottom. You can see share.
Entire screen is next below.
Entire screen. You click on entire screen. Then bottom there is a share icon. Just click that.
Share audio system.
No, sir.
Ready? Dr.
You
Shiva?
can see entire. Once you click share, then
Hmm.
one window will open. There you can click entire screen or screen, whatever icon you just select, then share. Bottom there is another, again you have to click share again.
Share I have already clicked, not opening.
No, it is not opening.
Can you please send your presentation via mail to CSI headquarters? We'll share it from our end, and if you can call the slides, we'll show the slides. And meanwhile, while you are
Yeah. Now got it, sir. Now it is. Yeah, now we can see. You click minimize this window. Minimize this window.
I'll minimize which one?
Current window you minimize. Current window minimize. No.
Then
Do one thing, sir.
stop sharing.
No,
It is
don't do, sir. Don't click. Yeah, PPT, open PPT, sir. You can open PPT now. Wherever it is, just open your PPT.
yes, open it.
Make full screen.
Then is it visible there?
No, again it went. Just click PPT again. Oh, okay. I got it. We can see your PPT. Make it full screen. You know how to make full screen?
I can make full
Yeah,
screen.
make it.
It's there.
Yeah, please start with go to first slide and start. Done.
Okay, friends. On the auspicious day of this hypertension World Hypertension Day, I have the pleasure to be with the Cardiological Society of India headquarters with our president, um, Dr. Dhiman Kali, then our secretary, Dr. D.P. Sinha, and President-elect Dr. Satyendra, Dr. Mrilan Gandhi, Dr. Roy, and other friends. So it is a pleasure to be with you and sharing the thought on the day of World Hypertension Day, where we have to uh, think about how to control the blood pressure throughout the world. In that prospect, I'm assigned to speak uh, about importance of blood pressure, the home blood pressure measurement. Controlling hypertension together is a different concept that we have to first detect the high blood pressure, then treat it properly and see for the sustenance, and as a social message how to modify the lifestyle so that the incidence can reduce. In a world of around 8 to 800 to
Sir, are you
1000
changing
crore
the slide, sir?
population,
Are you
it is
changing the
around
slides?
150 to 160 persons suffering from hypertension. And in that context, in India, around 40 crores of people are suffering from hypertension. The first thing is the detection of
Sir,
the.
sir, are you changing the slides or it isn't?
I am
Okay.
shifting.
Okay,
It's
okay.
okay, shifting?
Yeah. Now it's
Okay. So the first thing is you have to define and detect hypertension. That is, we have defined blood pressure by different guidelines, and the latest may be like this: the normal, elevated, stage one and stage two, 142 more. But these are the we check basing on the office blood pressure. All these guidelines has total date has been decided basing on office blood pressure, and all the guidelines, all the research till now is mostly focused on office blood pressure, which has limitations. But today, if the blood pressure is more than 180 or 110, the you can start treating, and if it is less than that, the issue has come about uh, what is the real blood pressure. So today we have standardized what is a standard office blood pressure, um, putting the person in a without caffeine, without smoking, in a proper sitting position with a standard digital blood pressure with a validated machine. We check the blood pressure and diagnose the what is the blood pressure of the persons. So after this, the concept came whether the blood pressure, what we see in the uh, office, is it real in the real day life or it is something different. So then the concept came that it is of course already equally 40-50 years old, like the hypertension detection. If the persons are not may not be having the similar blood pressure in the day-to-day life what we see in the chamber of the doctors in the office. So from that we got the concept of ambulatory blood pressure or out of the office blood pressure. One is a ambulatory blood pressure, another is a home blood pressure measurement, or it is also some uh, guidelines say it is the self blood pressure measurement monitoring. So basing on that, we can see that the if the office blood pressure is 120, it is almost in the night time can be 110, which is called the dipping with the ambulatory blood pressure, and with a ABPM maybe 115 by 75. It is when we see that the office blood pressure is always a little higher, but sometimes it can be different. It can be white coat means it is increased in the chamber of the doctor, or it can be masked means it is normal in the office but very high when they are going outside. So what is their significance? And in course of time we thought about uh, that the mass hypertension and the um, other varieties of phenotypes like the orthostatic hypertension, nocturnal dipping or nocturnal rise, morning rise, orthostatic hypertension, all these issues have to be also addressed. But what we see in the office is just a snapshot. We just take one reading, 2 to 3 reading, average it and give to the person. So the person can also have a white coat because of anxiety or because of the rush of appointment, all those things. But even he's going back to his home, the home blood pressure is something different, and that is a natural relaxed blood pressure. We can capture it by the ambulatory blood pressure or home blood pressure. Ambulatory is expensive and is not reimbursable, and not practical always with all the people. The technical difficulties are there. So, but a home blood pressure today possibly can be practiced, which can identify what white coat hypertension, or it could be a false alarm. So unnecessarily we treat a lot of people if the blood pressure is too high in the office. So they can be taken into account if the blood pressure is taken later and it is normal. And the danger is the masked hypertension, which is 1 in 8 patients. And they are at high risk of CV events in course of time. So better CV outcome prediction comes when we go for a home reading, and it is well correlated with the target organ damage. There are studies like a OASAMA study which shows that it is well correlated, started from the year 1986 by OASAMA in Japan, and still continuing one of the largest study for the home blood pressure, and they found a good correlation with the CV outcome. Similarly, another study is by the Pamela trimodal comparison, and it shows that there is the risk is higher if the and the risk mortality can be predicted better with the home reading. These are a lot of bunch of studies with references predicting the home blood pressure and the office blood pressure comparison prediction in relation to stroke and cardiovascular outcome. So the better correlation with LVMI is found with the ambulatory blood pressure. The reliability is in the systolic blood pressure, in the office blood pressure, home blood pressure is better reliable and well correlated with the left ventricular mass index. As we are progressing from 2008, we have started adopting this concept of home blood pressure measurements. 2008, we detected the white coat hypertension. In 18, the ES guidelines put it as a class 1. And today it is the universal consciousness that the home blood pressure measurement is essential for hypertension titration, detection, authorization, treatment, and follow-up. So the recommendation today is like this, that the elevated blood pressure one it is there, then and the hypertension is more than 190. So in this situation, we have to analyze what is the prospect. The diagnosis of hypertension and elevated blood pressure confirmation using out of office measurement by either ABPM or SVPM at at least an additional subsequent office measurement will be useful for diagnosing properly a patient of hypertension. So these are the important issues. The protocol for confirming the hypertension diagnosis today is the greater use of out of office measurement unless it is more than 180 by 110 or when the patient is in emergency. So these patients we confirm today the blood pressure is by ABPM or by SVPM. So we should take a correct measurement similar to the office measurements. 5 minutes rest, taking the back support, arm level, no caffeine, and two readings in the morning and evening, and if optional they can take more readings in the house. Choosing the right tool is more important. It looks for proper validation of the equipments today, and in that context this research has come that the IntelliWrap, total wrapping the arm, is very important in using the bladders in the machines. So these limitations of SVP is incorrect technique, device inaccuracy, anxiety, and self-measurement bias. So what are the advantages of this home blood pressure? Can take multiple readings besides the two standard readings we advise for 7 days. Avoid white coat reactions for blood pressure, reproducible, and predict severe morbidity and better than the office. Can diagnose white coat and masked hypertension. Allow patients for better understanding of hypertension and management, and telemonitoring allows for professionals from distant places, and we can detect the increased BP otherwise in these patients. So limitations is the device quality, inaccuracy, cuff size, the risk of change in the treatment by patients themselves without consulting, lack of nocturnal reading as we get with the nocturnal dipping with ambulatory 24 hours record, not yet reimbursable by insurance. So the take-home message is that this should be ABPM should be a standard protocol or should be used for a proper diagnosis of the different phenotypes of blood pressure, if that less than 180 by 110. And we need more use of this ambulatory BP in our day-to-day practice for both detection, confirmation, and also treatment follow-up, and also subsequent maintenance of the blood pressure. It needs more randomized controlled trials to understand the treating the blood pressure to be determined by both uh, out of office like a ABPM or SBPM in course of time. So thank you very much for the patient hearing.
Thank you. Thank you, Dr. Mishra. And now we call upon Dr. Satyendra Tiwari for his deliberation on ensuring compliance and hypertensive therapy. Over to Dr. Tiwari. Dr. Tiwari, could you just come forward or just walk down and make the screen a little bit angulated? Come forward. Angulate your laptop screen, please, slightly.
Yes, sir.
Share
Yeah.
screen.
Okay, fine. Fine, here, share your screen.
President-elect sir, you are muted.
Yes. Can you hear me?
Yes, sir.
Yes.
Okay. Can I go to my slides?
Please, please.
Can you see my slides? Can you
Yes,
see?
yes, visible.
Okay. So thank you very much. Today is the World Heart Day, a very important day for all of us, not only in India, but also uh, uh, globally also. And
Video. Please turn on your video, sir.
sorry.
Sir, you are not visible.
The slides are visible. Sir, okay, go ahead. Okay. Go ahead with the slide.
Now you are visible, sir.
Just a
Now
minute.
kindly share again, sir.
Right,
Yeah,
yeah.
yeah. Can you see now, sir?
Yeah.
Can you see the slides?
Yeah, sure. Please.
Okay. So, thank you, Minalda, Dr. Sinha, Dr. Ray, and all the EC members and delegates. So we are going to, I just want to share a very important concept of how to ensure the compliance to the antihypertensive therapy. So there are newer approaches to improve the adherence, simplify, leverage the technology, including team-based care and the objective and how to move forward to make the improvement and to the adhere to the treatment protocol. Yeah. So as we all know that this poor adherence remains the challenge. It's a barrier for all of us for the BP controls. So most of the time we think that it is a drug failure, but it is not so like it. And so the patients, they disconnect the therapy. And this non-adherence is as high as 50%, and approximately half of the hypertensive patients do not take medications as prescribed. And this leads to a 3-time risk involvement, leading to multiple organ involvements, and other comorbidities. And 1 in 3 are persons, almost 1/3 of the patients are still, the blood pressure is uncontrolled. So uncontrolled hypertension is disproportionately driven by the non-adherence and not specifically related to the therapeutic inadequacy, making adherence the highest yield intervention target. So to conceptualize the concept, there are so many pillars. I'm focusing on the major 5 pillars. One is the regimens, how one should go ahead. And the most important is the single pill combinations, because it also helps in better adherence, longer supply, and the cost reduction is one of the major factors. The other pillar is the digital involvement involving the various health apps. SMS reminders, telemonitoring is important. And the third important pillar is the involvement of the team, the nursing staff, the pharmacist, the community health workers, which are directly in communication with the physician on one hand and the patients on the other hand. And the fourth important pillar is the assessment whether the drug is really effective or not by biochemical testing of the molecules, the drugs, both in blood and urine samples, and then monitoring the blood pressure control for pretty longer time. And there are emerging approaches like ingestible sensors, packaging innovations, and the system level changes. So this is a multi modality framework where the drug combination, the involvement of the technology, multidisciplinary teamworks, this all offers and helps in improving the adherence and sustainability of the blood pressure controls. The first pillar is the single pill combinations, which lowers the forgetting rate. Patients forget if you write, many drugs. Sometimes he misses the drugs, sometimes not having the correct doses. There is a faster blood pressure control as compared to free combinations. It reduces the therapeutic inertia in the clinicians. The physicians, they are hesitant to increase the dose of the drugs to the maximum levels and then shifting to and combining with the other drugs. It improves the persistent at the initial 1 to 2 years. The last year, both ACC and HA, they recommends that it prefer initiating the 2 first-line agents like ACE-ARB with calcium channel blockers, then as a single pill for stage 2 hypertension. And these single pill combinations, they are more sustainable and they are evidence-based. There are many strategies. And this reduces the pill burden while accelerating the blood pressure control and minimizing the clinical inertia. So how to dispense these tactics that reinforces the adherence and improves the blood pressure, especially the systolic blood pressures. So instead of giving for 4 weeks or 8 weeks, then one can make it to a 90-day supplement. Then patient continue for 3 or 4 months as compared to 4 weeks refill, which is associated with significantly higher medication and the chances of missing the drugs, not adhering to the proper doses, and then aligning all the prescription to one pickup date. So it reduces the faster much burden on patients frequently visiting to the clinician or to the hospitals and improves the multi-drug adherence. And the third most important, which is a big barrier here in our country, is the cost. So by instead with generic drug molecules and formulating and review and remove the financial barriers, so which helps in patients' adherence to the drug for pretty longer time. So the longer supply to the patients, which synchronizes the refills, reduces the cost further, and this prescription is close to adherence gap at the systemic level. This involvement of the pillar 2 is the digital health, use of digital health, which helps in medication and reminders, frequent reminders by using various health apps, which pushes the notifications, alarming to the patients, the attendants, and then re-emphasizing, as Dr. Mishra has said, the home blood pressure tracking and self-monitoring tool is a big benefit to the patients. frequent SMS and text messages to the patients, telling them about the correct doses, the timing, the side effects, and then monitoring that whole data of 4 weeks and reanalyzing whether he is taking the correct doses in correct timings, and virtual educating the modules, and then use of the Bluetooth to enable the blood pressure device integration. And all these helps in reducing the systolic blood pressure 2 to 10 mm of mercury initial 6 months. It has a stronger effect with the intervention. So this multi-component apps which outperform the single features tool, and it's become some quite meaningful and benefits in the health disparity populations. And so there is an involvement of the multiple component programs which underserve the populations in our rural population. It is very important. As you can see, the various SMS apps alerts which monitor there is a self-monitoring home blood pressure tracking to the patients. He can assess how the blood pressure is moving and then sharing the data with the clinicians to the nursing staff, and then digital therapeutics, which is artificial intelligence driven. And this behavioral coachings helps in each layer, adds value in adherence, improves the outcome, the better systolic blood pressure control for longer period of time, representing the emerging clinical frontiers. So basically, there is a multiple involvement of the team, the physician's level, which initiates the drugs, set clear blood pressure targets, reduces the therapeutic inertia, involving the nursing staff, the pharmacist, which helps in giving the instruction to the home blood pressure monitors. It is protocol-driven titrations. One can modify the doses depending upon the appearance of the side effects, and then counseling the patients, and then refilling the doses to the patients. And then role of community health workers is equally important, because at physicians level, at cardiologist level, it is very difficult to monitor each and individual patients. So these community health workers helps in navigation, the support, and then cultural bridging is very important. And all this combining the clinical expertise. So there is a behavioral support and the community engagement for comprehensive patients coverage. So if you combine all this, it leads to shared decision making on the regime choices. And this digital technology helps in confirm the patient understanding, whether he understands what are the goals, what are the side effects, and how to explicit these BP goal communications. By this, almost one can adhere the improvement to 76%. In almost 8 to 10% of patients, the mean additional systolic blood pressure reduction is achieved. So a proper coordination which improves the adherence and deliver the meaningful additional systolic blood pressure reductions, making pharmacist integration a high value team investment. So feels that there is a proper follow up of the blood pressures, and it helps in the community to larger extents. So the home blood pressure, it gives immense benefits, as Dr. Mishra has said in earlier talk. It accelerates the medication titration decision much faster. It reinforces the patient engagement and ownerships. It reduces the white coat effect on the clinical decisions making. It provides actionable data for team feedback loops. So this home blood pressure monitoring combined with the structured team feedback, it reduces the therapeutic inertia more effectively, which sustain longer. And there is a vicious cycle. When the data is shared with the team arrives to a conclusion and then adjusts the doses and helps the patient's outcomes. So the blood pressure controls is become faster. It lasts longer with sustainable blood pressure control for pretty long time. So objective is to self-report by biochemical testing. That is the fourth pillar. So whether the drug is really effective or not, one should get the drug test detection by using its strength in the plasma, in the urine, which becomes more objective. And so it gives you immense confidence whether the dose is proper, whether the drug is working or not. And then this data get recorded, And then there is at a population levels, it helps in communicating with the patients that it's really have active, and patient feels that he is part of the team. And also it reduces the cost of the whole treatment is subject to manipulation, best used along with the other methods. So by self-reporting, it enables the accurate diagnosis before escalating or changing the therapy for a pretty long time. So a personalized carrier barriers targeting the interventions like the barriers are the challenges are the forgetfulness. Patient forget to takes the pills, it's become a routine, and then notice the side effects frequently which is happening, and then motivating the interviewing the patient, educating them, and then it builds the trust between the patients and the physician and the cardiologist. And certainly it reduces the cost of the patients that he's not coming to the hospital and again. So it motivates by, and then it's has a lot of lifestyle modifications, its habits improve, the goals he know how much blood pressure has to be reduced, and that is becomes educative for others to follow. So there are multifaceted intervention involving the team, the digital technology. So these are the barriers by which we can improve by these newer approaches. So after identifying these barriers, one can produce the most durable improvements in adherence for long time, which has become the chronic diseases. So there are emerging supportive approaches like smart packaging, the blister packs with a visual calendars, the color coded by a day, so he cannot miss the doses, the dose confirmation. So, and then ingestible sensors are being used by digital technology, which confirms that the drug is properly absorbed and it's really effective. And it helps the infrastructure to improve. There are wearable integrations, the newer approach that continuous blood pressure adjacent monitoring via wearable enables passive tracking and real-time alerts, which augmenting the traditional home blood pressure monitoring. So these are the frontiers to represent the objective real-time adherence confirmations. That's equally important. So to combine that there is a technical health community clinical pharmacy care, there are challenges with the cost, and there is a cultural trade, the lifestyle modification, all being working together for sustainable adherence requires formulation design favoring generics, single pill combination, telehealth, involvement of the community health workers. It helps in reimburse models, and then it helps to the populations. So all these leads to the addressing access, affordability, and equity alongside the individual adherence strategies. So if you combine all these combined strategy consistently outperform the single intervention. So not only the physician or cardiologist are interacting with the patient, but the whole team, the health workers, the nursing staff, and then these digital technology. It reduces the systolic blood pressure to, further for pretty long time. And there are meta-analysis which tells that digital tools add incremental benefits gradually, especially when layered within a multi-component approaches. So all patients, if you combine, there is a prescribed single pills combination, which when it is appropriate, one can use it. Educate with the technical backup support to the patients, encouraging the the home blood pressure monitoring, and then your team follows the patients whether he is following it or not, whether the blood pressure is properly controlled 24 hours sleep, and then optimize the supply and the cost to a pretty long time. So all these helps in assess the adherence objectively, identifying the specific barriers, personalize the interventions. So regular digital reminders, SMS, educational materials, and these multifaceted approach outperform the single strategy. So those who are non-responders, so maximum adherence across the full patient population, one can achieve by using these newer approach for the treatment of the hypertension. So patients' shared decision is equally important, the basic foundation for treating these patients for pretty long time. So patients understand the value of dialogues, So if there is a joint decisions making, patients who participate in the decision, they build trust along with the physicians. So there is a better therapeutic alliance. And this linking medication taking to daily habits. So there is a lifestyle modification from a simple evidence-based behavioral anchor. So there are various studies which has proven that adherence intervention that builds the ownership, the trust, and the long-term engagement while treating the hypertensions in the to the patient and to the community. But there are ongoing challenges, there are limitations, like in our country, which is have heterogeneity in the studies. So there are variable population based problems. So one should understand the outcome, the difficulties, and then one should use the resources to a better way. So one can use the technology dependent strategies and then follow up these patients for 6 to 12 months and implementing the various barriers and solve it out. So despite strong evidences for multiple strategies, heterogeneous trial data, short-term follow-up, and equity consideration are paramount in treating hypertension. So to conclude, the simplification is using the drugs for at least for 3 months. It reduces the cost of the patient visiting to the hospitals, use of technologies, various SMS, telemonitoring, digital therapeutics, and then home blood pressure monitorings, and all these along with the use of your team, the hospital, the nursing staff, the team workers. So there is no single strategy which is dominating. Even in last year, the AHA and ASA says that combining all these strategy makes the direction endorsed by last year by AHA and ACC. It has become outperforms any single approaches in treating the hypertensions. So to conclude, so by default, this strategy treating the patients involving the technology, and it helps further reduce the systolic blood pressure, which benefits most effectively in multi-component program for more than 6 weeks, 24 weeks. Engage the team, not only the physician, the pharmacist, nursing staff, which produces the high-yield tech back with a home blood pressure monitoring closed data, measuring objectively whether the drug is being used properly, how much effective, whether the correct dose is used, and then share decision making with the patients and address the various barriers involving the patient in every step. So probably on this hypertension day, one can say that not a single approach, but uh, the multiple approaches can help in controlling the blood pressure to maximum. Thank you very much.
Thank you, Dr. Tiwari. That is an excellent delivery. And now we move on to the most important part of this today's program. We have a panel discussion which will be moderated by none other than Dr. Minal Kantidas. And I think he has prepared some pointed questions to all the members, senior members and delegates and members.
Sir, by mistake, I mean, it is, yeah.
Yeah. Dr. Minal Kantidas, yes.
Good morning to everyone. We guide group of bodies today for speaking about hypertension. We had two good discussions and two good discussions on various points. Now I'll try to explore something more that we have been so far. And to start with, I'll ask Dr. H.K. Chopra. First question on triple gap. We know that we have got huge burden of hypertension the range of 220 million people in India at present having the hypertension, but still we have got significant lack of awareness, significantly reduced treatment rate, and much less is the control rate. So, Dr. Chopra, could you highlight some of the points regarding this triple gap?
Thank you very much, Dr. Das. I think it is a brilliant question. And if you see the data of ICMR or WHO or even the World Health Organization, 90% of patients still are uncontrolled. The control is only 10%, which is a matter of great concern. So I totally agree with you that a time has come on this occasion, as the theme is mission hypertension awareness is the need of the hour. Because the theme is control hypertension together. Together should be defined. What do you mean by together? Doctors and of course, Satyan Tiwari also mentioned comprehensive care and home BP monitoring. They are definitely very, very important. But awareness rate is very important. And I remember the data published somewhere in 2016 in Indian Heart Journal by Dr. Ramakrishna. And he mentioned in that data that 42% were hypertensive, but they are not aware. So awareness is the need of the hour. And I personally feel that CSI should launch mission hypertension care so that we create a massive awareness in the people's mind. As we all know, the major population is rural, and they come to us mostly with the complications. By the time they have CKD, or they have a heart failure, or they have a stroke, or massive MI, so they have all kind of vascular insult. So I think, I personally feel, and I agree with you, that mission hypertension should be launched as a pre-primordial, primordial, primary, and secondary strategy.
Thank you, Dr. Chopra. I think and the next, let us go to the next question. As you know that India's condition right now in terms of the hypertension in young is very much predominant. And the shift has been there from the elderly age group to the level of 30 to 40 years of age. Now I asked Dr. Soumitra Ray to highlight some of the points why it is so and how can we take care of the rising incidence of hypertension in young.
Thank you, Dr. Dash, and very good morning to all my senior and juniors over here. Yes, I'll go even a bit earlier, Dr. Dash. About 10 years ago from AIIMS Delhi, Professor Anita Saxena led a study on teenage school children of 4 states of India, that is Haryana, Gujarat, Goa, and Manipur. And they found 23% of these teenage children are already hypertensive. So that is very scary. And 40% of those children are obese. So it is not 30 or 40, it is 15, 20 when we have the hypertension. So we start everything 10 years earlier, you know. Our parents marry 10 years earlier, we are born 10 years earlier, so we are hypertension also 10 years earlier, and we die 10 years earlier. So I think we are a decade ahead of the rest of the world. So it's no wonder that our hypertension is predominantly younger hypertensive. The problem with the younger generation of India, particularly in such a country, that the young generation are either very much ambitious, driven by their socioeconomic condition, or they are frustrated, jobless, and they are going into habits like smoking, habits like junk food, habits like computer games. So there is no outdoor exercise, there is no proper counseling, no proper yoga, pranayam sort of thing. So this kind of thing has to be addressed. I personally feel it's very important for us to screen the people, not on railway station or on shopping mall, but in your clinic. When a patient comes, usually he or she is accompanied by his son, daughter, or son-in-law, daughter-in-law. So why our nurse or the clinical attendant in our clinic check their blood pressure? The patient's attendants, who are younger people. And that way, I think you can get a huge number of young people get detected of hypertension. It's very simple, just a bit of orientation. And once it is detected, there are problems of long-term treatment of pharmacotherapy, particularly in the female of childbearing age. Many drugs cannot be given. So lifestyle is very, very important. So address their diet, address their salt intake, their body weight, their day-to-day habits, their stress and strain, and their outdoor exercise, their hobbies and habits. Everything have to be addressed. And I think that's a big way of detecting and addressing the issue of young hypertension in India.
Thank you, Dr. Rai. And it's really a silent killer to a great extent. And that's why I asked Dr. Anjala Doctor regarding this particular aspect, the silent killer. What are the markers for the silent killer in hypertension?
Thank you, Dr. Das. All my friends, good morning. This is a very important question in terms of our achievement of hypertension treatment. Why do we really treat hypertension? Because hypertension leads to a series of effects on the heart and the different organs, which is clubbed together as end organ damage, which is again reflected in atherosclerotic CVD. So if you look into the entire scenario of cardiovascular disorder, hypertension plays a very important role. It may be microangiopathy, it may be macroangiopathy, it may be organ-directed damage. Say, for example, microangiopathy, you must look into the microvascular changes of the kidney, particularly in terms of albuminuria. You can have effect on the eyes and retinas. You can have effect on the heart as initial everything. Awareness of the patient, awareness of the society, public awareness, everything is important. But I personally feel that we must train our patients. If you go by figures of blood pressure, not by symptoms. And then what I want to mean, many patients who, sir, I had my blood pressure checked 1 month back, I'm feeling fine. If you're feeling fine, does not mean that your blood pressure is fine. You must not go by symptoms alone. You must go by your blood pressure recording, either done by yourself or by doctor or by your sisters, technicians, physicians, health workers, whoever is competent in checking the blood pressure the way we want advising to do it. And that is important. So we need to prevent end organ damages in the form of proper treatment. And end organ damages means they are the silent killers of hypertension in terms of various complications. Thank you.
Absolutely fine. And we must go on searching for the early signs or early markers. And echocardiography is a very good tool to detect left atrial enlargement or stiffness, and then the ventricular end-diastolic pressure rise. So all these markers must be taken into account. Now, we have already discussed about the various points regarding the measurements and how we can take care of the various methodologies regarding the correct measurement. Let us now delve into something different to Dr. Ashok, P.K. Ashokan. Please, you just give us some idea about incorporating wearable devices in detecting early hypertension, mid age of hypertension, or even in the subsequent follow-up. Wearable devices.
Dr. Ashokan sir, you are muted.
So thank you, sir. First of all, let me congratulate the CS headquarters for arranging a seminar on this World Hypertension Day and starting hypertension mission all over India. So, as you all know, that this hypertension is the prevalence is very high in urban areas and is increasing, and is a social disease and also a biological disease. So when you come into the social disease, what we are seeing is the hypertension prevalence is increasing in young population. And it is very important to create awareness and also improve the adherence to the treatment. And coming to the adherence of treatment, as Dr. Professor Satyen Tiwari, President-elect, said, the digital usage of the digital device is very important. And the control of the hypertension is very important, and you see the home blood pressure monitoring, otherwise also the ambulatory blood pressure monitoring. In these aspects, the wearable digital applications is very important. One is to look into the controller of the hypertension in the office as well as at home, and second one is to adjust the medications. And the only thing is, it should be cost effective and should be availability should be to make sure all over our country, and so that we can improve the adherence and the control of the hypertension.
Thank you. Yeah. Thank you, Dr. Ashakan. Lifestyle measurements and lifestyle observation is very, very important. And the high salt intake is a very much problematic area where Indians are facing. And let me ask Dr. H.K. Bali regarding the high salt sensitivity in terms of causing hypertension and perpetuating the hypertension. High salt sensitivity and salt intake. And what is your recommendation?
At the outset, I would say that Cardiology Society of India is doing a great job in raising awareness about hypertension. And we all know that's a silent killer. And worldwide, it is the #1 killer. Now, it's a lifestyle disease, and diet is the most important component. And as you very rightly said, salt intake is a huge problem. And we need to spread awareness to people that we have great evidence from experimental data, from animal data, from trial data to show that higher the salt intake, higher the prevalence of hypertension is worldwide is. And sometimes high salt intake may actually negate the effect of the drugs also. So we need to create awareness to people that we need to go as low on salt as possible. 2 to 4 grams per day is sufficient in most people. And one important component is that if we go to cooked food, or what we call as a processed food, or in the restaurant, or wherever we go to eat food outside, we don't have any data to show how much salt is there in the food. So we need to create awareness that people should know how much salt they're taking, in what form they're taking that salt. And that awareness will go a long way in controlling blood pressure and preventing the occurrence of blood pressure in young. So we need to create an awareness, and everywhere in eateries and restaurants, we need to tell those people that as a routine, there should be availability of how much salt, how much other components are there in every food we are taking. And if we can control salt intake, we will go a long way in controlling blood pressure, along with other lifestyle modification like good exercise, regular exercise, and stress control. So all those components would help us in preventing blood pressure. We had a great discussion. Dr. Tiwari's lecture was extremely good. But I think preventing blood pressure is going to be the way forward. Because if you look at the 22 million people suffering from blood pressure, is huge. And that impact will come in years to come, and it will be a very adverse effect. So we need to prevent blood pressure, and that is going to take care by taking care of our diet, salt intake, by exercise, regular exercise, and by preventing stress, starting from early childhood. As Dr. Sumitra very rightly said, now we're seeing younger people coming with blood pressure, and that is happening because of diet and the processed food, salt intake. So we need to very definitely focus on the amount of salt we take, and decrease the amount to at least 2 to 4 grams per day, not more than that. Thank you.
Absolutely right, and we must recommend the salt intake below 5 grams per day. And the same length, I am going to Dr. Shuman Bhandari to put you the question on the metabolic syndrome nexus, the nexus of obesity and insulin resistance in generating hypertension. Dr. Bhandari, unmute yourself. Dr. Bhandari, please unmute yourself.
Can I get the question again? I didn't understand it fully.
What is the obesity insulin nexus in perpetuating the process of hypertension?
Yeah, so I think it's a very good question and pertinent because obesity is on the rise and cardiometabolic syndrome, the starting point is obesity and hallmark is of course insulin resistance, hypertension and hypertriglyceridemia. So obesity causes more hypertension because of its effect on the cardiometabolic syndrome and we need to correct overweight and that itself can reduce blood pressure by about 5 to 10 millimeters of mercury and exercise and now GLP-2 GLP inhibitors will add to our ability to control the weight much better now.
Thank you. Thank you, Dr. Bhandari. And now I ask a very, very important question to Dr. Arup Das Biswas regarding the shift of the hypertension from urban to the rural background or rural areas, which is coming in a very big way. And let him highlight about the rural shift. And at the same time, I would also request him to put his point regarding the CSI advocacy in this particular area.
Thank you, Dr. Das, for asking this question. Good morning, everyone. It is nice to see all my friends from all over India and also from the headquarters. Nice to address you. Now, you have raised a very important issue because the rural population is the largest segment of population. So we cannot neglect it. And the problem of hypertension, as we see from the epidemiological studies, that it is increasing in the rural population also. If it is all over India about 30%, the prevalence, it will be divided equally, almost equally between the urban and rural. However, there are some statistics showing that urban is 35, rural is 25 to 30, like that. But it is no doubt it is increasing. And the age bias, that is also decreasing, earlier onset of hypertension. One of the factors may be stress. The other factor is that migration. We are always hearing about the migrating integrating people. The rural stress about politics, society, these we cannot ignore. And another problem that we often forget is smoking. So if you just allow me 1 or 2 minutes, I'll be talking about one thing, that is we have to educate our people, not only the person who is affected, but his family members, particularly what I have observed in my more than 40 years of practice, that if I talk with the daughter about his father's hypertension, it comes to a great help. If I talk with the son regarding his mother's hypertension, they can help in prevention. And also it is important to possess one home BP monitor if each and every family cannot process it. In the rural as well as in the slum areas, they can form a group, or we can have it distributed to the school teachers or panchayat members. So detection and control, these things should be heard. And I think what to be picked up, which machine, that is also important. It is flooded with mushroom-like growth of BP machine. Professor Das was talking about wearable machine, but I am just concerned with the major problems with the BP machine itself in purchasing. So go to some site like stridebp.org and choose your BP machine from that which suits your pocket. And also maintain it properly. Often we have seen that BP cup is not maintained properly, filled with fungus. The battery is worn up. It is not renewed. So these things are important, keeping the machines in proper shape. So coming back to the rural population, education important, smoking, cessation of smoking that is going rampant, even among the youngsters. What we see that they are leaving the schools and going to smoking and other kind of environment like possessing a mobile phone, leading to sedentary habits. So salt, smoking, sugar, sedentary habits, stress, these are the all hastes. So we have to simply educate them. I think we can go on for speaking for long, but just rural bias is very important. This should be our message. And we should publish some papers for common people, not like Indian Heart Journal with very elegant statistical data, etc. Simple language and distributed them either electronically or by printed matter. Thank you. Thank you.
Yeah, thank you, Dr. Das Vishwas, for your suggestions. I think CSI will take up all these issues in future. Now I request Dr. P.C. Mandal to say something about the various guideline targets of high blood pressure. You know that the poll is changing from time to time, and the recent guidelines have also changed the course. And what is the current status regarding the the targets of high blood pressure?
Thank you, sir. Good morning to everyone, and respected all seniors. And that regarding targets, it is really a challenging area, but the ACC in 2025, that means 14th August 2025, they have given the guideline that's 120 to 130 is elevated blood pressure. And more than 130 needs treatment, that is stage 1, and their preference is more than one drug. That means 2 drug combinations, and stage 2 means 140 by 90. That means that was the target initially from different guidelines, and now the ACC guidelines is 120 above needs attention. If there is any, we have to go to the prevent score and calculate the risks. If it is more than 7.5 in 10 years risks of cardiovascular disease, then it should be treated. And otherwise, comorbidities, because 95% of the hypertension is complicated, not simple. Even in old age, isolated systolic hypertensions are sometimes associated with movement disorders or dementia. That means they need more attention. It is a strong correlate of dementia also. And we have to accept that guideline that 120 is our target. 130 plus means needs drug therapy. 140 plus means stage 2 hypertension, needs combination pill, along with today's theme, that is, we should react together. That means patient, family, healthcare provider, and policy makers. That means salt substitutes, even remote monitoring, all to be allowed. And regarding other guideline that has been given, particularly they are addressing the Japanese guideline. They have the highest, longest data of blood pressure and its organ damage. That has been given by Dr. Seshu Shankar Mishra, that Japanese has the longest interval of initiation of study and commenting. So that to be accepted, and their guideline is also same. That means 120 will be our target, and 130 plus means need treatment, and 140 plus means need aggressive treatment and evaluation for organ damage. And we should accept this today's theme. We should react together, involving family, involving social workers and healthcare providers, and also policymakers regarding suppose salt substitutes or other monitoring also. Thank you.
Thank you, Dr. Mandal, for giving quite huge descriptions about the targets. And one must accept, in fact, in the last Hypertension Council meeting, we had a discussion amongst all the cardiologists from India. And we thought that 130 by 80 should be the standard target, but definitely 120 by 80 is the recommended guideline by American College of Cardiology. And if we can achieve that without much side effects of the drugs, then definitely it's welcome. Now, Dr. Bharti, could you tell something about how you unmask the pseudo-resistance of hypertension? Pseudo-resistant hypertension. How you unmask? You unmute yourself first. Unmute. Dr. Bharti, you unmute.
Yes, yes, sir. Good morning, sir. Actually, thank you for inviting all of us, and thank you to all of you. Actually, pseudo resistance is a phenomenon. It may be due to fault of the measurement, or the patient is taking drug or not. This is the important issue. Sometimes patient is not taking drug, and that will be confirmed by some urinary measure of drug or the serum level of drug. That is a pseudo resistance. Another issue, sometimes very older age group, sometimes pseudo resistance due to hardening of vessel, and it causes more systolic blood pressure. So in this issue is solved by measuring the intra-arterial pressure or the by other methods. These are the very important. But how it is a confirmed, it is pseudo resistance or true resistance? It is a very important for every patient, because if you treat the pseudo resistant, definitely sometimes very harmful effect to patient. So these are the very important issue, and it is solved by only by the patient relative is taking drug or not, really is taking drug, if the patient taking diuretics or not. These are the very important issues. And
yeah, thank you. And in fact, pill counting and laboratory, pharmacy, all these can give some insights about non-compliance, and also can unmask the cause of the hypertension. That delve into the real resistant hypertension, Dr. Manoj Bansa, could you tell me something about the renal denervation, which is a very practiced kind of intervention in resistant hypertension?
Sir, renal denervation, after there was initially loss of interest because the results were not very favorable. Now, under supervision and under trials, renewed interest is there in renal denervation therapy in truly resistant hypertension. And as a part of these trials and monitored therapy, renal denervation may be beneficial to these patients, sir.
Definitely, when all the drugs, 3 or 4 drugs fail, then renal denervation has got a role, and it has shown benefit up to 12 months. Now, very important complication or the sequelae of hypertension is the stroke. Now, Dr. Arvind Kumar, are you there? Dr. Arvind Kumar? Okay. Then if Dr. Arvind Kumar is not there, Dr. P.C. Manoria is there? No. Okay. Then I asked Dr. D.P. Shina about the stroke burden in hypertension and how should we mitigate it.
That's a very important question. You know, India is a country with an epidemiological transitional state. And gradually, the current data indicates the number of strokes are exceeding the number of MI in the Indian population. That is what happened in the advanced civilizations also, that number of strokes exceeds the number of MI. So the current burden of hypertension, which starts in India in a very pretty young age, in the school-going age. In fact, in our school health survey that we are conducting at the present time, we are finding a disproportionately large number of childs with hypertension. And these will ultimately be the base on which the number of strokes will increase. So if you look at the prevention trials, it is shown that 1 millimeter of mercury blood pressure reduction in the population leads to 2% decrease in stroke, but hardly any decrease in coronary heart disease. When you were a student, this question was asked why it is so. Now it is being proved that there is reduction in coronary heart disease, but to a lesser extent than in stroke. In future days, we are going to have much more number of strokes unless we are able to control the hypertension. In this control of hypertension, certain things will be important and certain things cannot be dependent. Wearable devices like smartwatches and other things, they are not a reliable tool for blood pressure monitoring. Blood pressure has to be monitored by a standard cuff, preferably at home. This is being stressed regularly. If we can control the blood pressure to that extent of below 120 or as low as reasonably achieved, alara principle, then the number of strokes can come down. Otherwise, we are looking at an epidemic of stroke together with MI. Thank you.
Thank you, Dr. D.P. Shina, for your beautiful description about the condition.
Cashless monitoring.
Yes.
This cashless monitoring, as per HSC guidelines in the last year, August 2025, actually is a class 3 indication. It will misguide the therapy. Cashless monitoring all include like smartwatch and other things.
Right. Now, yeah. So Dr. Shina has already given the warning that we have already crossed half an hour more. Now, what was the moot point that or the theme of the World Hypertension Day was not only to take care of the hypertension but also to go together. So, who are these people who should go together? It has been already highlighted to some extent: doctors, nurses, then ASHA workers or health workers, government, media, and people. All these people will have to work together to come to give adequate control of high blood pressure, and that will lead to the reduction in the various, complications or sequelae of hypertension. With these few words, I thank all the participants and the super duper cardiologists for giving insights to the control of hypertension in today's program. Thank you all.
No, vote of thanks. I have to give a vote of thanks. Yes. All good things must come to an end together. Today's meeting, which has been attended by 14 live participants and nearly 200 online participants, we must conclude today. I give my vote of thanks to all the respected past presidents, esteemed DC members, moderators, panelists, and distinguished guests, and their participants. It is my privilege to propose the vote of thanks for at the conclusion of this important program of the Cardiological Society of India on World Hypertension Day. On behalf of the Cardiological Society of India, I express my sincere gratitude to Dr. S.S. Mishra, Dr. Satyendra Tiwari for their enlightening presentation on home blood pressure monitoring and improving compliance to anti-hypertensive therapy. Our special appreciation goes to Dr. Mrinal Kanti Das, past President CSI, for effectively moderating the panel discussion, and to all past presidents and executive committee members for sharing their valuable experiences and perspectives. I also thank all participants, organizers, technical teams, and supporting staff whose efforts ensured the smooth conduct of today's program. Let us continue to work together with greater awareness, prevention, and control of hypertension in our society. Thank you all and wish you good health, control blood pressure. Jai Hind, long live CSA. Good health, control blood pressure. Good afternoon. Good afternoon. Good afternoon. Bye. Bye. Bye.
बंद करो नहीं